Hello and welcome to Two Peds in a Pod, the paediatric medical education podcast. I'm your host Ian Lewins, and I'm delighted to bring you this extra special guest podcast this week discussing the COVID vaccine. And it's brought to you by Doctors Damian, Roland and Ali Monroe.
Hello there, my name's Damian Roland. I'm a paediatric emergency medicine consultant at the Leicester Royal Infirmary, and I'm chatting to Alistair Monroe. Do you want to introduce yourself, Ali?
Yeah, hi. So I'm Ali Monroe. I'm a paediatric clinical research fellow in infectious diseases at Southampton, and I spend a lot of my time now doing COVID vaccine trials and some research about COVID in children, as well as moonlighting in the paediatric emergency department, and I contribute to Don't Forget the Bubbles, which is how you and I became so embroiled, Damian.
Yes, and it's lovely to hear that you're enjoying moonlighting in the children's emergency care world. Because if you're going to moonlight anywhere, that would be the place where I think people should moonlight.
Absolutely.
So we're chatting today, clearly as paediatricians, but we're involving this, I suppose, podcast for anyone in the medical profession, really. And we'll either get questions from patients, but probably more importantly from family and friends about the COVID vaccines. So I just wanted to really cover some of what is known about them, and we'll try and move through this in a way that is understandable to a lay member of the public. And I suppose the first big thing is a lot of these vaccinations are known by the name of the company who's creating them, rather than what the actual vaccine does or how it works. So do you want to just take us through the different types of vaccines against COVID that have been created?
Yeah, absolutely. And there's loads of them. There's absolutely loads already. It's quite remarkable, actually. So I think at the moment there's roughly 60 different vaccines in clinical trials that are being trialed in humans, and there's about another 90 nearly in preclinical studies as well. So plenty to choose from. But obviously, most people are probably familiar with the front runners who have been making news headlines recently. So we'll just go into. I'm not a vaccine developer myself, so I can't give you the real detailed nitty gritty of the science. But we can sort of give a quick umbrella overview of the different technologies that are being used at the moment. So the one that people are talking about a lot at the moment is the Pfizer vaccine, and this one is what's called an mRNA vaccine, and this is similar to one of the other front runners, which is the Moderna vaccine. And so these use messenger RNA to code for an antigen. So just to remind everyone, the way that a vaccine works is obviously it's trying to show your body a piece of either a virus or bacteria that we call an antigen, which is normally a protein. Show it a piece of these bad guys so that it develops antibodies already. And so you have some pre-existing acquired immunity when you meet the virus or the bacteria in real life. So you're very quickly able to ramp up massive production of antibodies in your memory cells and that immune side of your immune system to help you clear infection. So all of these vaccines are just different ways of trying to show your body bits of the virus. So we're obviously talking about the SARS-CoV-2 virus that it needs to recognize. So mRNA is using messenger RNA, which is like the recipe for a protein that is then injected into muscles in your body, and your muscle cells use that code to produce the antigen itself. So the antigen is not in the vaccine, but the recipe for it is in messenger RNA. And then
and I think that's quite an important kind of point, isn't it? So a lot of people, I think, have got confused by one, they just have never heard of mRNA before, and the closest thing to that is DNA, and then they assume that the DNA of the virus is being injected into you, but that's not actually the case, is it?
No, it's not the case at all. So there's mRNA vaccines. There are actually DNA vaccines as well. So DNA is like one step removed. So in terms of what would normally happen within your cells is you have DNA, and DNA is like the original recipe, and then that's coded into mRNA, and it's from the mRNA that protein's made within your body. So there's sort of two different messengers that you can inject into yourself that code for the protein without directly giving you the protein. And mRNA is the one that's in the front runners. And it's fascinating technology because it's never been used in a licensed vaccine before. So there have been other clinical trials for other types of vaccines, but this will likely be the first ever fully licensed vaccine that uses mRNA technology, and it can be made very quickly. I think the Moderna vaccine was produced within 2 days of the full genome of the virus being released, which is astounding, really astounding. So we've got.
I presume that means that they were just wait. A lot of people have been scared about the pace of this technology becoming available and getting the vaccine to market. But part of that is because these companies are actually quite geared up to do this through their other product lines and the fact that they know what's going to happen. And all they really needed with the mRNA, that's the only new part of the technology. Is that right?
Yeah, that's right. And it helps that we have some pre-existing knowledge about this type of virus. So we know about coronaviruses and we know about sort of spike proteins and that being one of the primary antigens. So once you've got the code for that, a lot of these companies have the technology to very quickly be able to produce mRNA that will code for that antigen. And so that's how they were able to do it quickly. And that's the mRNA and DNA vaccines. But this also applied to some other technologies. So one of the other famous vaccine technologies that are being used at the moment include use in the Oxford AstraZeneca vaccine, and that's what we call virus vectored vaccines. And what this does is takes another virus which is either harmless or has been inactivated. So in the case of the Oxford one, it's a chimpanzee adenovirus, so like that would cause a common cold in chimps. And that virus is genetically modified to either produce the same antigen on its own surface or to contain the genetic material for that protein so that your body makes it. And so, for example, Oxford have a long history of making these adenovirus vector vaccines, and they'd made a similar one against MERS previously. So a lot of the technology was sitting around and already in use, and that was why it was so rapidly be able to be deployed for these things. So we've got the mRNA, DNA vaccines, we've got viral vector vaccines, then we've got something called whole virus vaccines, or inactivated virus, which is where you actually take SARS-CoV-2 and you either smash it up or mutate it a bit or give it some radiation or whatever to basically make it far, far less virulent or harmful, but it obviously contains all of the bits that your body needs to still recognize it. And then the fourth type is what we call protein ones, which is where you actually you give a dose of the antigen. So, in this case, it's normally the spike protein, and that can come with packages of other proteins or adjuvants to help elicit a stronger immune response. Those are the four types.
Just because the ones that have got to market quickest, which appear to be the mRNA and the Oxford's AstraZeneca kind of type approaches, are the ones that are actually furthest away from the COVID molecule itself.
Yeah, it's interesting. I mean, those are the ones that are in the West, but I think the one that was used that was deployed in China first was a whole cell inactivated one. So I think the one that the Chinese have been using for their military is.
And do we know anything about the impact of that vaccine yet?
I haven't seen any data, no, so I'm not entirely sure, no.
Okay, so it's clearly something to look out for. So we have different types of vaccines which have been developed. There have been questions and concerns about the speed by which these have been brought out. Now, I'm not an expert on the MOHA, but I've certainly been involved in enough studies and especially some kind of clinical trials that have been needed in children to license some products to know that they're a pretty well-governed bureaucratic organization and they're not going to let things through the net pretty quickly from my experience. And so that the weights and measures to all these vaccines, I presume, have come through so quickly because everything else has been put on hold for all the time to go into processing the application rather than the fact that they're taking shortcuts.
Yeah, absolutely. And you and I, Damian, who have been involved in clinical trials, both know that the cogs turn slowly in those systems. That once you have got absolutely reams of paperwork to fill out that needs lots of different people, very, very busy people involved to complete. You submit it, you wait for months, you revise it, you wait for months. You need to set up, huge databases and start advertising and all that, and go through ethics, all this other stuff. It takes the bureaucracy is massive, and a lot of that is for good reason, but it's just a very slow moving machine. The difference this time has been that everyone has stopped everything else to do this as quickly as possible. And people have poured huge sums of money into ensuring that teams have the resources to be able to go and get it done quickly. So having been involved in the Oxford vaccine trial, I mean, it was like a runaway train. It came so fast. It was so big. It was absolutely astonishing. And the amount of time and effort people had to put into getting it up, getting it going, getting patients in and vaccinated and followed up was absolutely astonishing. And a lot of it is just because, people have removed a lot of the barriers that are so time consuming, and stuff has just been expedited. So it's not that any less has happened. It's just what needs to happen has happened. A lot of it simultaneously, and then a lot of it, just incredibly rapidly. So, for example, starting the phase 1 trial was done, phase 1 trials were being started the day of or the day after results from, the animal trials being released. Whereas normally, you might start planning it on the day that happened, whereas they were actually getting going. So a lot of that has been what's facilitated the speed. It's not that less has happened. It's just what would normally happen has happened at an absolutely astonishing speed.
So, and a lot has happened. Can you give us some idea of actually how many people have been part of some of these trials? Because we're talking tens of thousands of people already.
Oh yeah, absolutely. I mean, so I know that the 2 phase 3 trials that have finished for the mRNA vaccines both had more than 30,000 participants each. I think the Oxford trial's got 20,000 going up to 30,000. We're enrolling in several other trials that are having thousands of patients. So we're probably talking hundreds of thousands of patients already enrolled in phase 3 trials. I think there's 13 phase 3 trials ongoing. I don't know where they're all at with recruitment, but yeah, I mean, it's probably over 100,000 at least patients have been enrolled, or participants have been enrolled.
And so what are the steps now, having had kind of some of the vaccines have been approved, will come out, more will follow. What will you be particularly looking for over the next 6 months or so in terms of data for kind of efficacy and effectiveness? I know we've had those reported, I suppose, by media statement, but I presume there's more to come on actual the real world as we're seeing it as the vaccine's deployed.
Yeah, so I guess, that's a big question because there's a lot. So first of all, it would be really great to see the full published data sets, as you said, from the phase 3 trials that have, reported their press releases. Probably the most important details are there, to be fair. So we know roughly how many patients have been recruited. We know how many, what we call, events there were, meaning how many people became infected.
And presumably the MRHA have seen all of these.
They'll have seen all of this and so much more. I mean, I imagine they'll have received hundreds of pages, if not thousands of pages of documents from all of the studies to review all of the safety. So they'll get all the safety information, not just the headlines about serious events, but, all events that have happened and summary reports of all of that sort of stuff. So everything that happened in a trial, even if we thought it was unrelated, they'll be able to review all of that as well. So, the important safety information we need to see. So we know that I think the Pfizer vaccine had a median of 2 months follow-up for its participants. So half the participants had 2 months follow-up. And that's probably the most important time period in terms of the possible, bad side effects or adverse events that we sometimes see related with vaccines. So where there's been cases of autoimmune conditions like Guillain-Barré syndrome or transverse myelitis, or there was narcolepsy associated with the H1N1 vaccine in children. Those have all occurred predominantly really within 2 months. So there's very few adverse events that tend to happen after that. So it's good that we've got that data, but we obviously want to see once more follow up has accrued, we'll want to be able to see that data as well for safety, for reassurance.
And I suppose it's important to note that we do know that some vaccinations have some side effects, but they have never been frequent enough to just stop using the vaccine completely, or that some of the outcomes are still under kind of debate and examination. My understanding is, especially for the narcolepsy, that there's still a lot of ongoing review about actually what the true impact is.
Yeah, absolutely. And there's always going to be events that are so rare that it's going to be extremely difficult to know whether they're related to the vaccine or not. I mean, that's the case in clinical trials, even, once you've got tens of thousands of patients. But then once you start rolling out a vaccine to hundreds of thousands of patients, you're going to see rare things happen, because rare things
happen.
do happen, yeah, particularly when, the number of people you're talking about is in the hundreds of thousands or millions. Trying to establish whether that is related to the vaccine or not is going to be very difficult. I hope that behind the scenes, whilst this emergency rollout is being planned, there's also some rigorous surveillance mechanisms that are going to have controls involved to see, whether things that end up happening to people after they've been vaccinated could plausibly be related to the vaccine or not. And then the other thing, as you say, Damian, is we know that all vaccines will have some side effects, even if it's just that it's sore getting the vaccine, and we know that we warn everyone, after you get the jab, your arm might be a bit sore, it might be a bit red and swollen, you might have a dead arm. And a lot of people, after a lot of, our routine vaccines, can feel a bit flu-like afterwards. And we know that's certainly the case for some of the new COVID vaccines. I think they're quite reactogenic, so they can make you feel a bit fluey for a couple of days. But we accept that those side effects or risks are outweighed by the benefits of the vaccination. And that, I suppose, that's to be determined if we see any similar rare events anyway. So Guillain-Barré syndrome is just associated with vaccines, full stop. We know that it can very rarely occur as a side effect of those, but it's so rare that in almost all instances the vaccine benefit outweighs that extraordinarily small risk. And in the same case, we always have to tell everyone that there's a risk of anaphylaxis for vaccines. I think it's about 1 in a million doses, but that's a real risk, and anaphylaxis is dangerous when it occurs. But we accept that the benefit of the vaccine outweighs that small risk.
And actually, it's interesting because millions of people are going to be vaccinated, so it is likely that risk will occur. And in the UK, we're about to, I think, going to try and vaccinate 800,000 people in the first wave. Now, in 800,000 people, some interesting and rare things are going to happen, vaccine or not. And that's going to be the problem for how, I suppose, the medical community and the media play this, because undoubtedly in the first week, even after the vaccine is given out, someone may have something happen to them that would have happened anyway. But because it's temporally related to the vaccine, all sorts of alarm bells might start kind of flashing up.
Yeah, and it's interesting because there are actually some parallels to draw with COVID itself, I think, in this instance. So it's not often that it's a once in a lifetime thing that tens of millions of people all become infected with a virus, within the space of just a few months, and some extraordinarily rare side effects of an infection suddenly pop up quite enough times that they make it into a medical journal, and people say, "Oh, look, this virus is associated with this side effect," which actually, in real terms, is probably a very, very low risk on per infection basis. But just because millions of people are getting it all at once, it suddenly gets reported. And like you say, there might be other instances that are temporarily related that actually may not have been related at all, and it's very difficult to know what was. Whether these things were related to the virus, whether they're related to other things that have happened. So I think there's some parallels to draw between the two. And I think it's going to be important that, like you say, there's a good sense of perspective is kept, I think, by the science community and the media in trying to look at this objectively. And I think it behooves us as scientists to put processes in place to be able to study it prospectively. I think it will be a bit of a disaster if we end up chasing our tails and trying to establish that kind of thing if we've not foreseen it and trying to put robust surveillance mechanisms in place first.
So, final question, Ali. So we've talked about just kind of the immunizations in general. What about specifically for children? When are we going to start vaccinating children specifically? Over what time scale? And will there be anything about that that's different from adults?
That is a really good question. So I think one of the things we first have to realise is that there have been no children enrolled in any of the COVID vaccine trials, to my knowledge, so far, except the Oxford trial, in which there were children in the phase 2 study, children aged 5 to 12, for which we don't have the results yet. And I believe that Moderna have just said that they're going to start vaccinating children aged 12 plus in their study as well. So we don't have any data on efficacy or safety in children. Now, we don't have any reason to believe that it wouldn't be effective, particularly if the vaccines so far look like they're very effective in the elderly people. We know that children will produce effective immune responses, but there's obviously different considerations in children because their immune system is different and it's maturing and it responds in different ways. There might be different side effect profiles and different considerations for some of the different vaccine technologies in kids. So I think it's going to be really important to see that data. And that's particularly because children are not a priority for receiving the vaccine. And that's primarily because their risk of severe disease is so low in absolute terms, and especially relative to the other at-risk groups. So, for example, in the UK, the Joint Committee on Vaccination and Immunisation have, set out their priority list, which is essentially by age, really, and then care home people who live in care homes first, and the people who work with them, because obviously they're a bit of an unwitting threat to the care home residents, and then people over aged 80, healthcare workers, and then it basically descends in age, and in addition some groups with comorbidities who might be higher risk, but kids aren't even on the list so far. Kids are sort of in the et cetera statement at the end. And it's for two reasons. So one is, again, the low risk, but then the other thing is that unlike flu, kids are not the primary vectors of the infection either. So in terms of interrupting transmission, kids do transmit, and eventually, if we want to maybe even come close to eliminating the infection, we'll almost certainly need to immunise children to achieve that. But they're not the most important factor, unlike they are for other conditions where we do prioritise immunising kids. So, for like the nasal flu vaccine, we like to get that into kids because they're important in the transmission chain. So two issues. One, we don't have the data. And then the other one is that they're low down the list. So we've got time to wait, I think, for the clinical trial data to come out, so hopefully before we get round to a stage where we'll be looking at wanting to immunise children.
Well, is it a possibility that we just won't immunise children if we go through all the high-risk groups and get down to younger adults and get to the stage where the transmission is so reduced, the benefits of kind of including children just aren't worth it?
I guess that is theoretically possible. If we did vaccinate enough of the population, it might become a vaccine that you get offered once your age, 40 or 50 or whatever. If so many people at the high risk groups have already been vaccinated and enough virus has circulated that there, is sort of enough immunity in younger populations that helps suppress transmission as well. If you've got a load of young adults and children who are already immune because they've already had the virus, then obviously there's much less impetus to carry out huge mass vaccination campaigns. I think probably at the moment people are working on the assumption that we'll probably try to get to everyone, but if that takes years and years, then we may conceivably get to a stage where we say, well, hey, we've only got so much of the vaccine, let's just focus on giving it to those who need it, because kids are not really significant risk and there's enough immunity around them to protect them.
Excellent. Well, thank you very much for that. I think that's a really useful kind of discussion, recap of the different types of the vaccines coming out, kind of how they're deployed, what we should expect, and a bit about kids specifically. So thank you very much for your time, Ali. Hope to speak to you soon.
Thanks, Damian.
I hope you enjoyed this week's episode. If you did, please tell your colleagues about us, and you can find us on Spotify, SoundCloud, iTunes, Google, and Amazon. Thank you.